A warm welcome to everybody from around the country. So good to see so many people interested in this topic. I must say, Matt and I were extremely pleased that Dr. Rudnick and Dr. Davis took on this topic. We feel that thinking about philosophy as it relates to practice is maybe not something that we get a chance to do every day in our world. We often go about our daily practice, and we hope that this morning will give you an opportunity to pause, to reflect, and to consider how important philosophy is and how thinking about our daily actions can be rooted within philosophy and principles. And so we're really thrilled to have our guest speakers with us today, and thrilled to have you with us, interested people in learning some more about this topic. So thank you kindly. We do this every time, but just so you know who you're working with, Jordan Clark is our technology master in BC, who helps us develop this platform and keep it up and running. Dr. John Higginbottom, whose brainchild this whole advanced practice it was. So we're very grateful to John. Matthew on the picture on the extreme top right. Matthew's here with me in the room, and as ever, we're very grateful for his ongoing technical support and his lovely radio voice we've decided this morning. So we're very grateful to him for that. And Regina, you hear from me frequently on the bottom right-hand corner. So that's our team. You know that BC Advanced Practice is funded by the Ministry of Health, and what you hopefully know as well is that we're one of 4 advanced practices: early prevention and intervention, developmental disability and mental health, and ACT, all of whom have individual advanced practice. So if that's an area of your world that you wish to get more engaged in, we recommend that you just Google those and you will find them, and please connect with them because there's some amazing information on there. We just want to say a big thank you to our instructors for their support and expertise. Please know we could not do this without them, and they do this on a volunteer basis, so we really appreciate their help. And after today, we will have 18 archive sessions that we hope that will be useful to you, and where as a family member, as somebody with lived experience, as an educator, as a policymaker, wherever you come from in the world, we hope that information is useful to you in your world. So our purpose is really to support clinicians, managers responsible for providing and developing PSR services, thinking about evidence-based knowledge, providing expert clinician consultation, and we've done that with a couple of teams. People have asked us to come and talk to their organization about PSR and how to implement PSR principles. We're developing training and education events. We'll tell you about the conference. Developing website resources, and you'll see on the PSR website we have an updated annotated bibliography. We're hoping again that that's useful to you, and we have a number of different videos that we hope are useful to you as well. And part of our role too is supporting the Provincial Advisory Committee and the community of psychosocial rehabilitation practice in general. So we have a large mandate, and we're hoping really that we are of value to you in your work. We also just want to alert you again to the upcoming Psychosocial Rehabilitation Conference. We're thrilled. We have about 250 people registered at this point. So please come and meet your friends and your colleagues. We think of ourselves as a small family, and in that family we are really interested in advancing our psychosocial rehabilitation practice. You'll know that we have keynote speakers from Dr. Kim User, Dr. McGurk. We have Dr. Wendy Eady from Alberta, who will speak specifically about hope. And then we have Brent Seal, who will speak about his lived experience. Do want to point your attention to the Institute on our very first day. There are many amazing ones. One in particular will speak about the new recovery-oriented guidelines from the Mental Health Commission of Canada. And it's a bit self-serving, this announcement, because myself and Dr. Skye Barrick will also speak a little bit about our experience with this new, fresh document, and how we can maybe begin to roll it out in our practice as family members, loved ones, people with lived experience, policymakers, and people delivering service. So that promises to be an exciting session, and hopefully for some, a new glimpse into the recovery-oriented guidelines for Canada. So with all that in mind, let us go to introduce our speakers. Oh, before I do that, the evaluation. So just a reminder to you that we honestly read every piece of evaluation that you send to us, and it helps us develop new sessions. So we really appreciate for that ongoing commitment to the evaluation, and let us know how we're doing. And if you have topics of interest or you wish to present topics of interest, we really would like to hear from you. So please keep that coming in. So now we move on to our two speakers today. So I'll introduce Dr. Abraham Rudnick and Dr. Simon Davis. So first you see a good picture of Dr. Rudnick, who's waiting with bated breath in Victoria on the other end of his computer. And so we'll just give you a little bit of background. Dr. Rudnick is a certified psychiatrist and a PhD trained philosopher. He's an associate professor in the Department of Psychiatry and the Ireland Medical Program, as well as an associate member of the Maurice Young Centre for Applied Ethics at the University of British Columbia. He is the medical director of mental health and substance use services and the head of the Department of Psychiatry at the Vancouver Island Health Authority. He is also a Canadian certified physician executive at the Certified Psychiatric Rehabilitation Practitioner and a staff psychiatry at the Victoria Mental Health Centre in Vancouver Island, British Columbia, Canada. Dr. Rudnick is also an adjunct professor, associate professor at several health sciences and research institutions across Canada, and the founder of the Canadian unit of the International Network of UNESCO Chairs of Bioethics, and the recipient of the PSR RPS Canada 2014 Pioneer Award in Recovery Research. So lots of background and academic perspectives in terms of thinking about this topic. And then we have Dr. Simon Davis, who's sitting here beside me in Vancouver. And Simon Davis is a manager with Vancouver Coastal Health, responsible for Granby Woodlands mental health team and mental health consumer and involvement initiatives. So that really means supporting initiatives from people with lived experience within the organization. He is also an instructor at Douglas College, thankfully, and UBC School of Social Work, and also the University of Fraser Valley. He is the author of Community Mental Health Practice, the second edition, that's published by UBC Press, and it is one of the textbooks that we use with our students at Douglas College. So welcome to both people. We will start first with Dr. Rudnick, so just give us a little moment to shuffle about, and we look forward to a lively session around philosophy and ethics.
Thank you, Matthew. Can you hear me well? Just waiting for Matthew to type that to see if I'm heard well. Okay, is this better now? Okay, thank you. So I'm Rami Rudnick. I'm a psychiatrist and a philosopher and a medical administrator, as you see in the bio. I'm always available at my Hotmail, and the reason I give my Hotmail, particularly today, is that I'm actually moving from BC back to Ontario this summer. The chief of psychiatry at St. Joe's Hamilton and a professor at McMaster. But I am ongoing doing courses in PSR. There's a course I'm doing in Vancouver this month with the PSR Canada conference, then in October at the CPA, and then in Muskoka next summer, a whole week for people who want some more kind of drilled in PSR education. So with that, I'd like to focus today on philosophy and recovery-oriented psychiatric / psychosocial rehabilitation. As usual, for physicians at least, I have to disclose I have no conflicts of interest that I can identify for today. So the objectives for my presentation today to enhance knowledge of philosophical aspects of recovery-oriented PSR, to enhance awareness of practice, implications of philosophical aspects of RO-PSR, enhance awareness of leadership implications of that, and enhance awareness of research implications of that. So first, let's do a refresher of Philosophy 101 to give the right background. In philosophy, we distinguish different areas of focus. They do overlap, but still, it's important to understand the differences. First, and perhaps the most veteran, going back to the ancient Greeks and even before, we talk about metaphysics and ontology, which is about what exists in the world, and sometimes why that exists. And there are many different philosophical approaches to understanding the world and understanding beyond the seen or sensed world. A very maybe famous example would be Immanuel Kant's 18th century take on that. And Immanuel Kant perhaps very honestly said, we can't actually know what exists in the world. That's called the noumena, the things that are beyond our observation and our senses, and but we can still think about them and speculate about them. And then there are more contemporary approaches like critical realism that attempts to better understand what stands beyond our senses by constructing a dialogue between our reflection on our sensory experiences and our sensory experiences. And there are many, many approaches within that. The second area of philosophy, which is particularly important to my research, is epistemology, and within that there's a special area of philosophy of science, and that's about what we can know and how we can know that. That means even though there are things beyond our experiences that we can maybe only speculate and reflect about, there are things we can actually observe and learn from. And particularly in philosophy of science, there's been a lot of attempt in the last century to try to hone the methodologies of that, eventually flowing into methods of research, including health research, to try to use optimal tools to understand the world, both the external worlds as well as the internal human worlds. An example which I very much follow as one school of thought in philosophy of science is critical rationalism, which was founded by Karl Popper in the early 20th century. And this is a skeptical approach to science, saying that we can never know reality, that we can never reach truth. Okay, I'm seeing that I may have to increase my volume here, and it's a bit tricky with my computer. Are you hearing a bit better now? Okay, I'll just get a bit closer to the mic here. Sorry for the somewhat basic equipment I'm working with here at VIHA. So critical rationalism, the skeptic approach to science, but a positive skepticism, saying that we can learn about the world and grow our knowledge. It's just never certain. And we have to be always critically minded, both about our theories as well as about our evidence, as well as about our experience, including lived experience, because as Popper's student Joseph Agassi has published about, none of us have privileged access. We think that we know our lived experience better than anyone else, and we probably do, but we actually do not have privileged access to our thoughts and emotions. And of course, the seminal writings about that started 100 years ago with Sigmund Freud, about people not being aware of why they do things, and sometimes not even being aware of their hidden experiences, such as some of their deeply hidden emotions. The third area of philosophy is ethics, and I would say also following critical rationalism that political philosophy is an important part of that. Some would actually flip it and say that ethics is an important part of political philosophy, because political philosophy deals with the collective level, whereas ethics typically deals with the more individual level, although there is an overlap, as sometimes it's shown by utilitarianism, where we address things such as public health. And obviously that's such an important area. I'll highlight it a bit later. So I'll move on to the next and probably last important area of philosophy, which is aesthetics, and as part of that, philosophy of art, and that is what should we like and why should we like, and there are different approaches to that. Some are objective, some subjective. I prefer the intersubjective, about collective taste, but also individual preference, but I will not pursue that today. Just going back to ethics, the lay terms would be what should we do in life, particularly in relation to human beings, but also in relation to other beings, as well as in relation to the world. Now, ecological ethics is an important area these days. So an example of ethics would be principlism. That is still the most commonly used approach in bioethics, particularly in medical ethics, where we have a few principles of ethics and we try to balance them out, such as autonomy, benefit to the person, reducing or minimizing harm, which is non-maleficence, and then justice or fairness to everyone involved, including third parties, including the public at large. So, moving on to recovery-oriented PSR. Just a refresher, recovery of people with mental health challenges is a complex notion, and referring to clinical recovery, such as about symptom reduction, as well as other outcomes, such as more functional independence, is important, but isn't enough, because we also need to refer to personal recovery, and this is using Mike Slade's from the UK terminology, differentiating clinical and personal recovery. And personal recovery is seeking and having personally meaningful lives and valued social roles, whether symptoms reduce, and even whether or not functional independence increases. Recovery-oriented mental health services, not just PSR, are person-centered and community-focused as much as possible, so that the vast majority of the work is done in the community rather than in facilities such as hospitals, although there is a role for hospitals to play in that. But many of us claim that that's primarily focused on rehab readiness rather than the full rehab umbrella. And then a person-centered approach in mental health services includes being person-focused, being person-driven, person-sensitive, and person-contextualized. And for people who may want to look at some more detail about that, please feel free to refer to my book, and that's with David Rowe. It's actually from 2011. There's a typo here, not 2014. So recovery-oriented PSR is a set of mental health services that enhance both success, which is judged by other people, as well as satisfaction, which is judged by the person themselves, in environments of choice. And that means the person chooses their environments, be they residential, vocational, educational, social, recreational, spiritual, health and healthcare environments, and so on. So I want to highlight two areas of philosophical aspects of recovery-oriented PSR. I'll start with the epistemological aspect. I've written about that, and some others have, that because recovery is such a complex notion, we need to better drill in theoretically to understand that. What does that actually mean? And what are some of the opportunities in regards to that, as well as challenges, including conceptual challenges. And so what I've tried to tease out is, what are these processes about, and trying to relate them to other processes in understandings of health in general, as well as coping and other related constructs. And so one of my takes is that health in general is, at least in part, a set of processes that are about self-organizing. So if you think about the ancient theories of health, such as humoral or balance theories, as well as Eastern notions of health, again, balance, be it of chakras, be it of chi, whatever it is in the different cultures, then a lot of that is really about self-organizing. Homeostasis in the early modern medical thinking, both late 19th century and early 20th century, sorry for that, is also a notion of balance. And so I would argue that recovery is also trying to reach a balance, but a different balance, and maybe a new balance, because once a person has developed a serious mental illness, at this stage of the science, there is no cure. We're talking about reaching an adaptive balance, both internally as well as with the world, in order to do well, feel well, act well, so be successful as well as satisfied. And there's more work to do in that, but I would think that aligning recovery in that way with similar notions of self-organization could be quite helpful. Moving on to ethical aspects, then recovery-oriented PSR has some generic challenges of ethics that are common to other health issues, particularly in the mental health arena. There are issues of privacy, of confidentiality. There are issues of justice, including fairness to others, of, for example, resource allocation. And PSR isn't exempt from that, because resources are finite, and we have to determine both within PSR as well as between PSR and other mental health services, as well as between mental health services in general and other health services, as well as between all health services and other public services such as education and transportation. What is a fair allocation? And there is no gold standard to that, but there are general frameworks that have been put in place with applications to health resource allocation that are quite helpful. And so I won't go into those generic ethical issues, but I will try to highlight a specific issue. And I see someone is, Victor is typing. So I'll wait for the typing to come up, because there may be a question about that. Although I understand the Q&A is at the end of the session today. Okay. So maybe I'll continue, Victor, and I'll see what. So okay, I'll respond quickly to your question, Victor. You're asking, do you think there would be benefit to educate peer supporters in ethical philosophy? Absolutely. Now, there are codes of ethics to PSR. I think anyone who is a member of PSR RPS Canada is obliged to follow the code of ethics for PSR Canada, which is similar to the code of ethics of PSA in the States. But I would say going beyond that, there has to be ongoing education and training. So part of that is drilling down into the specific issues. And one of those issues that I wanted to highlight for PSR today is the issue of coercion. Unfortunately, with some of my colleagues, psychiatrists and others, a question arises sometimes, well, you know, we can coerce people into treatment under the Mental Health Act in BC and elsewhere. And people probably know the mental health acts are different in each province. They're province specific. And I would say working in both Ontario and BC, they're quite different, interestingly. But they can allow us to force a person into treatment if they're a risk to self or others due to their mental health issue. We can even do that in the community, not just in hospital. In BC, it's called extended leave. In Ontario, it's called community treatment orders. The question arises, can we do that with PSR? And then the question also arises, even if we can, should we do that? Those are ethical questions. So I've published about this, and my philosophical and normative arguments have been that no, we cannot, because there's a difference between treatment and rehabilitation. Treatment is very specifically about symptom reduction. Rehab is much broader in scope, and with recovery-oriented PSR, the goal is always based on the person's life plans. So if coercion is involved, we move away from person-driven, person-focused, for sure from person-driven PSR. And so I would claim that by definition, recovery-oriented PSR cannot be coercive. It does pose some challenges about the practical and theoretical aspects of working with some people who may be quite challenging in their goal setting. For example, if their goals are very unrealistic, or if their goals are posing a major risk to themselves or others. That is part of the art and science of PSR, but it doesn't negate the, to my mind, logical conclusion that recovery-oriented PSR cannot, by definition, be coercive. And I think that's quite an important message to send to PSR workers, to peer support, to service users, to their families and other significant others, to other clinicians, to administrators, to governments, that when we look at PSR in regards to, for example, residential settings, so housing, often we find a somewhat coercive approach. That is not PSR. Maybe sometimes it's necessary. For example, if a judge orders that, we have no choice, and the judge may have very good reasons for that, for public safety. But I think the default should be non-coercive PSR, and if it is coercive, it isn't recovery-oriented by definition. At least we need to recognize that and work towards a more recovery-oriented approach as much as possible within legal constraints. Practice implications. So from that, it flows to my mind that the culture of PSR has to be recovery-oriented. For example, it has to be related to education of and standards for psychiatrists and other involved physicians. We often leave physicians aside. I think that's an error, a mistake. I think it probably has good reasons. Sometimes the physician community has been quite resistive to a more recovery-oriented and or PSR approach. But I've done some work to try to improve on that, and it is possible. It just requires collaborative effort, because both in inpatient and ambulatory settings, if the physicians are not on board, often PSR, particularly recovery-oriented PSR, can't fully happen. We, physicians, do have a lot of influence, and I think physicians have to be involved and educated. And I think with the Royal College's emphasis in the last few years on PSR, there's more of an opportunity to do that. Leadership implications of this. So I've published about that too, about mental health leadership in general, not just for PSR. To be ethical has to be person-centered, and that means all the aspects I addressed previously, person-driven, person-focused, and so on. Obviously, it has to be evidence-informed, but when I say evidence-informed, I don't mean evidence-based. Many of you probably know the evidence-based pyramid hierarchy that McMaster put in place many years ago, and it's followed across the world, where randomized control trials and systematic reviews are the gold standard and so on, and that's important. But we do recognize the value of other types of evidence, such as lived experience. So evidence-informed rather than evidence-based broadens the scope of informing practice, but with different sources of evidence. Yes, randomized control trials and systematic reviews for sure, but also gray literature such as government reports, quality improvement projects, and last but not least, lived experience of service users, of their significant others, of service providers, and other stakeholders. And last but not least, leadership should be socially responsible, for example, with fair resource allocation for PSR and outside PSR. And I would say, sadly, that across the country and in many other countries, it has not been, I would say, a very fair allocation within mental health services and between mental health services and other services in the health system in regards to PSR. And that's unfortunate, because I think that the evidence and the lived experience shows very clearly that PSR is a core service, should be a core service, I should say, for people with serious mental illness. And so I would argue there's a case to continue to make to funders and policymakers that PSR is core. Interestingly, also, when you look at academia and what psychologists and psychiatrists and often even OTs and social workers learn about mental health, that's not a fair allocation of academic resources either, because it's very common to see a whole curriculum for nursing, for psychiatry, for OT, for social work, for psychology, that doesn't even have one course or one full set of seminars on PSR, which is unfortunate, unfair, and I think harmful. So there's a pitch to make also to academia, and not just to governments and health authorities and health organizations, to make PSR more of a core part of their work, and I think the ethics supports that. And research implications, considering how important lived experience is for PSR and other mental health services, I would say absolutely necessary when doing research in the mental health field, both in PSR and in other areas of mental health research, that a mixed methods approach be used. That means not just quantitative measures, but also qualitative data that can tap much better into lived experience. And as usual, and I've written about that too, I would say comparative research is much better than weaker designs. And the weakest design I know is pre-post, and I would say even that is somewhat comparative, but we can strengthen our research in PSR much more to address the philosophy of science perspective of comparison in any science, including physics, being a necessary component to reach sound conclusions. So with that, I'd like to end with just the list of references that I sent out, and feel free to ask me for any other references that I've published or anyone else has published by email, and I'll try to help you out with that. And I always encourage research collaborations, both in regards to ethics of PSR as well as empirical research, which I, of course, didn't focus on today much because that's not the major topic for today. So thank you.
And a huge thank you there for Dr. Rudnick's presentation. That was absolutely fantastic. We're going to have questions, and folks, if you have questions about Dr. Rudnick's presentation, you can hold on to them, and we'll sort of approach everything at the end there as a group. And I'm going to pass this over to Regina.
Thank you kindly, Matt. Just want to say a big thank you to Dr. Rudnick. You know, we're here, three of us, Matt, Simon and myself, and we're just, at least I can speak for myself, pretty passionate about some of the things we've just heard, and fired up, I guess, excited to hear just a focus on making PSR more of a core component of rehabilitation services and mental health services in general. And I really also appreciate the focus on that the evidence is there, and that it's supported by an ethical perspective as well. So really, we thank you very much, and we want to just put some of that content in a bottle and hang on to it forever and ever. So thank you kindly. That was very inspiring. Really appreciate it. We now pass you over to Dr. Simon Davis, who's probably going to speak a little bit more maybe from a clinical perspective. And we just want to say that really the joy of doing this presentation is that we're looking at this material from several different perspectives. So thank you very much. We're just going to pass it along to Simon Davis at the moment. So we're just getting ready here.
Hi. Hi, everybody. Can people hear me?
Yeah.
Today, I wanted to talk a bit about, as the title says, challenges in implementing a recovery-oriented approach to a community psychiatric service. So I'll be sort of wearing a bureaucrat's or manager's hat, or seeing through that lens a little bit. We'll try to tie it in a bit with what Dr. Rudnick said as well. In looking at theory and values underlying psychosocial rehabilitation, that model, how do we apply this to the real world of psychiatric practice? And a little more specifically, how do we honor and implement the values underpinning PSR and reconcile them with some professional, ethical, and organizational obligations, and reconcile them with the perspectives of other stakeholder groups? First of all, to start discussing that, just a little bit about what are the values and assumptions that underlie what we call a recovery vision or recovery model. One of these come from different sources and authors, and some seminal works from Patricia Deegan, and who is a woman with lived experience of mental illness who went on to complete a PhD and is probably fairly well known to a number of you. Also, the Boston University PSR program, and William Anthony, an academic there, now retired. But Deegan notes in the first bullet that professionals need to embrace the concept of the dignity of risk and the right to failure if they're to be supportive of us. So that, the idea of risk-taking as leading to growth, to support that, is now seen as a competency to be desired among mental health practitioners. Being client-centered or person-centered is obviously a big part of a recovery approach. Interestingly, I think there was a well-known article authored by Larry Davidson a few years ago about the top 10 concerns among administrators about implementing a recovery vision in mental health programs. And one of them was that we're doing it already, which was probably a debatable assertion. But indeed, if and we've all worked with people over the years who are very client and person-centered and have been. So even before we were calling that a recovery perspective, I think that's a core fundamental part of any of our approaches with folks with lived experience. Respecting autonomy and self-responsibility, the third bullet there. Dr. Rudnick spoke about minimizing coercion, which is a big part of when we're talking about recovery. There are some that believe that repetitive coercive practices will finally hammer away and break through and create insight, in quotation marks, among patients that we see, such as breaching somebody on extended leave or a community treatment order. And I'm not sure I would support that given the trauma involved in the succession of involuntary admissions to hospital. I also liked Dr. Rudnick's reference to self-organization as a definition of restoring health or of mental health or well-being. So that how do we support that? Anthony's quote there, that professionals don't hold the key to recovery, consumers do, is an interesting and a somewhat contentious one, because the response may be that if somebody is floridly unwell and unrecognizing of the perils that they are subjecting themselves to, is there not a role for professionals there? I guess one thought is that mental illness is episodic, and the majority of people will perhaps relapse, but that the period of time when they're at the period of incapability is a relatively small proportion of the time in the trajectory of illness, so that while there is room for crisis response, we've been too oriented that way in the past and not recovery oriented enough. Finally, there is a principle held by some that, by definition, the formal mental health system has its downsides to it, and that ultimately, hopefully, someone with lived experience of mental illness can move on to natural supports or informal supports. I've heard this told to me by people with lived experience, one-on-one and in conferences. There is also an American psychiatrist called Mark Reagans. You can Google him. He has an inventory. He runs a mental health community program near Los Angeles, and one of his criteria for recovery-oriented service in his inventory is that there is a built-in expectation about and process for what he calls positive graduation and leaving the formal mental health system. And I'll talk in a moment about some of the challenges around these. Dr. Rudnick very appropriately said that recovery is a complex notion. And there's still debate and confusion among my colleagues and among service users about what we mean by that. I do like the distinction he made between clinical and personal. I also sometimes refer to recovery from mental illness, which means presumably remission of all and most symptoms and restoration of functioning, versus recovery within mental illness. Was that Larry Davidson, Regina? And the idea that even with residual symptoms, people can enjoy a good quality of life. Defining measuring is very much on our radar, on my radar these days, because health authorities are more and more talking about accountability measures and metrics for evaluating what we do and how effective that is. Some of the metrics are performance indicators, such as readmissions to hospital within 28 days, which is considered an unsuccessful outcome, so that healthcare systems still rely on adverse events in many instances to evaluate what we're doing, that don't necessarily reflect quality of life. So that I think there is still room for the development of instruments and approaches that capture, that are a more holistic approach to determining how effectively we're working with our clients. There are a number of instruments out there that people may be aware of, and if not, we can forward you some compendiums. They're recovery tools that evaluate personal recovery and the recovery orientation of a mental health service. There's no consensus yet as to which ones are the best or better than others, although there have been some attempts to do that. There is, excuse me for stammering, folks, there are some tools that have been used mainly in the addictions field. The acronym is FIT, Feedback Informed Treatment, and people may be familiar with the session rating scale and outcome rating scale. If not, again, I can forward that, which are fairly simple instruments mandated in BCH for use among addictions counselors that measure both engagement and functioning on a sort of a week-to-week or month-to-month basis. And we've piloted that for use with a more seriously mentally ill population, and the jury's still a little bit out on their applicability. Accreditation Canada, one positive development is we're undergoing that as we speak in Vancouver, the accreditation process, and part of that is initially a self-rating of your service, and it's been very interesting to see in the latest iteration of accreditation standards how much reference there is to supporting consumer involvement across the whole spectrum, supporting empowerment, but also supporting sitting on policy-making committees, hiring committees, and that kind of thing. So that has been a reassuring thing to see. So a challenge then about defining and measuring recovery, because as authors writing on the subject have said, this is a subjectively determined matter. We do need to be client-centered. We do need to check it out. And as a colleague of mine, Renee Mohammed, a woman with lived experience, has said in talks to my team, one size will never, fit all. We do need to check out what recovery means to our folks that we're seeing. Just further to that point, I'm on to the next slide, top bullet. We find both working with service users one-on-one and also from reading the literature that a number of service users are still fairly congenial with a more traditional, for lack of a better term, medical model approach to providing service that may still be based around symptom remission and may still be focusing on medication as the key component in treatment. So the question then, I suppose, is if a service user is adhering to a more traditional conception of treatment, what is the role of the practitioner in exposing the person or encouraging a broader conception of mental wellness? Another concern that I've heard expressed by service users as stakeholders has to do with, you'll recall the bullet on one of the previous slides referring to a positive graduation as being a necessary part of recovery in mental health. a moving away from the formal mental health system to natural supports or more informal supports. I work with clients who, according to our acuity rating scales, are doing pretty good. They haven't had that many adverse events or hospitalizations in recent times. So on the face of it, they seem like they're doing okay, but they may feel stuck. They may also feel not well connected to other supports in the community. And a model of care initiative at BCH that is encouraging transitions of these people that have been determined by the American Level of Care Utilization System Survey as being less acute and complicated, and encouraging and moving them away from the team has been met with some ambivalence, at least, if not anxiety and concern about losing resources, about a lack of support. One of the things we must bear in mind is that we gatekeep and provide access to free or less expensive rehabilitation and other mental health services than people may get once they leave the system. So if we are being recovery oriented and looking for positive graduation, how do we wrestle with that? Oops. Sorry. What about physicians as a stakeholder group? How do they fit in with the whole recovery vision? I think Dr. Rudnick spoke a bit to this. Physicians, I mean, we work in multidisciplinary settings, but physicians and psychiatrists are still key members of the team and very influential. And may feel pressures and obligations a little more acutely than some of their colleagues. Doctors are obviously not unsophisticated people, as we, Abraham being a good example of that, and have I think a pretty clear understanding how it's not just about medicine and biogenetics, but there are psychosocial determinants of health that are important to address. However, there may be some question, as I think Abraham mentioned, as to what extent in training psychiatric residents are exposed to a PSR perspective. Perhaps Abraham can speak to that in the Q&A. There's some evidence that there is evidence of a strong influence of a biogenetic model in the pharmaceutical industry in helping characterize how we see mental illness. And there is a number of pressures, organizational and systemic, on psychiatrists and community settings that might work against perhaps being more recovery oriented. We could also ask, however, could we envision a system where the psychiatrist plays a role as an important consultant, but that in fact other folks, such as PSR professionals, may fill that gap. There are some papers I've read that psychiatrists being trained in Canada may not necessarily feel comfortable in providing cognitive behavioral therapy, which is an evidence-based, non-pharmacological approach to treating a number of conditions. It's interesting, too, that if you look at residency programs in Canada for psychiatrists, the Royal College still refers to a rotation in, quote, chronic care, unquote, which a term I'm a little bit uncomfortable and speaks to sort of the legacy of the medical model that we're trying to overcome. I think perhaps, that's okay. Regina, wrestling here with the computer. Thanks for people's patience. On this slide, the last two bullets, in my own experience, are key ones in understanding physician concerns about recovery. If recovery is about risk-taking leading to growth, what does that mean in terms of liability issues in possible claims of negligence on the part of a doctor who perhaps is not proactive enough in providing a more assertive or coercive intervention, such as an involuntary admission. Fiduciary duty, I refer to in the third bullet, is an interesting expression and concept. It sounds like you're talking about money, but in fact it also has to do with a duty of care wherein the welfare of an individual is entrusted to someone else's responsibility. So that could be a child with a parent, but a psychiatrist I once worked with at another teams told me she took very seriously her fiduciary duty to do the best she could to be the one taking over the care of the patient she was working with, which at the same time does necessarily, I guess, mean that it is a more paternalistic relationship. This is a definition of duty of care that I just pulled off the internet. A requirement that a person act toward others in the public with watchfulness, attention, caution, and prudence. That a reasonable person in the circumstance would. If a person's actions do not meet this standard of care, then the acts may be considered negligent. Psychiatrists I've worked with, I think, have an unrealistic fear sometimes, particularly in the Canadian context of litigation, but do feel very heavily the weight on their shoulders of the need to be cautious and watchful. And how then do we, as PSR professionals, work with our partners, our stakeholders as clients and psychiatrists to support that risk-taking? Health authorities tend to be risk averse. And this is a quote from a paper authored by several Australian psychiatrists that I think resonates with me. Services operate in a public environment where there's accountability to third parties whose priorities include individual and community safety. And certainly in Vancouver in recent years, there's been claims of a mental health crisis and requests from partners such as the city and the police to take a fairly vigorous approach, if I can put it that way, to managing what they see as a crisis. So priorities include individual community safety and likely have a low tolerance for adventurous services. Professionals will continue to err on the side of caution until they're assured the system will support them in times of crisis. Does the system support someone like me in cases like that? I work fairly closely with a gentleman who's in risk management and client relations, and I think he does a pretty good job of trying to balance safety and empowerment and supporting client choice. Nonetheless, when things go awry, as they have occasionally at our team, so that there's a serious injury or death, you're required to report to a critical incident review committee, which I've attended, and which is heavily weighted by doctors, and which in one instance I recall struck me as applying a fairly paternalistic approach to an unfortunate outcome that would have meant a considerable invasion of privacy and a considerable intrusion that I was not completely comfortable with. Nonetheless, one hope for people that might be listening to this webinar is that you have access to colleagues that you can bounce ideas around with, risk managers, supervisors, and apply an ethics lens. I think Abraham mentioned this. The core principles such as justice, beneficence, non-maleficence, and at BCH we're fortunate enough to have clinical ethicists. So if this is a resource that you don't have access to, I can only say that it's a valuable resource that hopefully people can ask about or develop. I'll get to my last slide, and then I think there'd be Q&A after this. The final stakeholder group I wanted to mention was families. Families are an important resource for us in PSR, support their loved ones, they provide us with information, and they help lobby for resources. There is something of an unfortunate legacy in psychiatry of some mistrust between service providers and family members for various reasons that I won't go into at this point. There's not enough time. But family members similarly have worries about safety of their loved one. They have worries about talk that consumers hold the key to recovery and not professionals. They would like a guiding hand oftentimes when they see their son or daughter in distress or talking about suicide. So how do we work effectively with family members to implement a recovery vision? Family members, again, I can forward stuff to folks if they're interested, but have been uncomfortable a little bit with the whole recovery discussion, thinking that means traditional clinical recovery and saying that a schizophrenic illness may be enduring. They have some concerns about, which I think are unfounded, hopefully, about resources being steered away from what they call serious mental illnesses to less serious. And there's been some real back and forth between family advocates and the Mental Health Commission of Canada with respect to the Commission's reports and strategy and priority documents. The challenge for service providers, as we know, is we have an obligation to our client to support their autonomy and empowerment. And if we, without consent, engage with family members about more coercive practices, how that can be a sense of betrayal felt acutely by service users. If anybody's interested in this topic, if you Google North Shore Schizophrenia Society and look at their advocacy bulletins, these are documents that reflect a concern about the recovery concept, a concern about safety, and a concern about professionals needing to be more sort of assertive, if not coercive at times. So, just to wrap up, I think in my lengthy years in the mental health system, I've seen some great advances. Certainly the PSR model, having colleagues here like Matt and Regina and other folks in the cyber room here, has been a very positive thing. It's been good that Accreditation Canada now is reflecting more about recovery in their standards. The Mental Health Commission has provided some good leadership. We have peers now successfully employed in a number of settings that has been a consciousness-raising experience for professionals who may have doubted their competence. We have better housing models, much better than when I first started, believe me, including Housing First, that are insufficient in supply. I think it's an incremental process implementing a recovery vision, one that needs leadership at every level, at line level and up. And it takes place, that takes place in quiet moments, I think in small moments, in discussions and meetings, having to do with us needing to reflect on the terms we use, on our body language, and that kind of thing. But nonetheless, I'm not going to present you with any easy resolution for some of these challenges, and I think I'll just wrap up at this point and turn it back to Regina and Matt. Thank you.
Well, thank you for a very thought-provoking morning from both Dr. Rudnick and Dr. Davis. We are so happy to hear from you with questions, so just as I summarize a little bit, maybe if you have some questions, please go ahead and type. And I guess for myself, really, I think we but gone with the big picture of what is philosophy, what is ethics, what are some of the challenges, how does it resonate with psychosocial rehabilitation principles and practices, and really getting to the place of what are some of the conundrums and how can philosophy and principle, how can they inform our decision making, and how can ways we consider ethics, how can they help advance our practice and begin to realize maybe more fully some of the implications and opportunities that psychosocial rehabilitation presents us. I see that some person is typing a question, and Dr. Rudnick, if you wish to type some answers as well, that would be really great.
He can't speak.
He can't speak, right, but he can type. So just make sure that you're included in the conversation. So we're very happy to hear from you. And our first question is, are there therapeutic resources you would suggest for working with families utilizing the recovery model? And so I'm not sure if somebody would like to respond to that. So the question is, specific resources you would suggest for working with families. So
in speaking ethnocentrically, I work at VCH. There is a family advisory committee that is supported by the organization, that is chaired by a family member, has some participation from service users. They have regular access to directors and have been able to make policy proposals and documents. VCH is also fortunate enough to have some dedicated positions in community and hospital settings of individuals whose role is to support family involvement. So we may be more resource rich than other jurisdictions, I'm sure. There are other, what I can do is, maybe what I'll do is to think about that a little more and maybe send out to Regina and Matt maybe some links to resources. There's a lot of good information for families out there on the internet, and the Kelty Center at Women and Children's Hospital is a very good resource, for example. But I will try to find more material and get back on that.
And I think just as we're waiting for some more questions to come in, hello me. I think also Simon and Dr. Rudnick also talked about leadership, and having worked with Vancouver Coastal Health for a little while, I think we had some really amazing leadership from family members and from some of our leaders within the organization in those early days, and building trust, building opportunities to work together. And so although we might have a resource-rich opportunity for participation at this point, I know that people worked hard to make that happen. So just an acknowledgement to individuals as well.
I'll just add, there is a recently completed family policy document that lists expectations for staff. So maybe I'll forward that as well.
Great.
And we can post all that on the website. And then Dr. Rudnick's got an answer there.
So Dr. Rudnick just adds, I couldn't hear, so we're sorry about that. But if not mentioned, we're also multi-family psychoeducation program by William McFarland, which is best practice per SAMHSA. Yeah, that's really, thank you for that addition. I think some of those documents really help us understand how we can move past that unfortunate history, I think, were Simon's words in terms of how we involve families within mental health practice. So thank you for that, absolutely.
There is other, of course, nonprofits such as BC Schizophrenia Society, or it's Canada-wide, and Mood Disorders Association, whose role is often to support families.
Dr. Rudnick adds, involved a few families and service users together, unlike traditional family education that excluded that. Yes, and that is certainly advancing in practice. So the idea being that it wasn't just for family members alone, but also for people with lived experience. And generally, I think historically, we've tried to separate those individuals. Sorry that we're moving the computer around. It's kind of like a Prezi presentation, so hopefully it doesn't make you a little dizzy. So we're happy to take another question or two. And as Matt said, if you can direct those questions to somebody in particular, that will just help us. Unfortunately, Dr. Rudnick cannot hear the auditory part, so that will just help us direct the questions. So if anybody has another question or two, we'll just hang tight. Oh my goodness! So we see a question here for Dr. Davis. How can we best support an individual transitioning from mental health team to community where there are still limited accepting resources in the communities, such as with leisure and recreation? Thank you for that question.
That's a really good question. One thing we've tried at our own agency is a kind of a stepped or graduated transition to the community, so that if the person is clinically stable, that they may be discharged from the psychiatrist at the team, but kept on as what's called a rehab-only referral for some months, so that the person is benefiting from, say, a CBT group or a wellness group. The big barrier when they ultimately do leave the team is cost, and in fact, whether these groups exist. People on disability income are eligible for subsidized access to recreation and other community services, but I acknowledge there's still a gap there. I don't know if anybody else hearing that question could maybe type in a response.
So thank you very much, Simon. Next comment comes from Tracy, who said, the challenges you have presented about judiciary responsibility on the part of psychiatrists and the risk aversion of many practitioners, including a fear of graduating people from mental health treatment programs like case management, is very common in practice. Have you found effective strategies to move service providers beyond these beliefs? My goodness, that's such an important and a big question, isn't it?
I don't want to be Pollyannish or unrealistic. I think if someone has been socialized for years or decades in a particular approach, it might be hard to shift that. But again, it requires leadership. It occurs in small moments. The individual practitioner does need to feel that they are being supported, which we get presentations and PowerPoints saying that it's not about blaming people when mistakes are made, but people may still worry about that. I mentioned a risk manager that I deal with fairly frequently, so that, for example, I present him with few conundrums. We have a fellow on extended leave or community treatment order. He wants to go off in the bush, leave Vancouver and hang out in the wilderness. What I found, to make a long story short, is that that director that I work with has been willing to support a fair degree of risk. And as well, when we do ethical consultations, we've been able to build a case for a decision that does support risk. VCH is all very much about harm reduction right now. So when substance users come into our building and sometimes engage in risky use in the bathrooms of the building, my director is still enforcing an attitude that we don't want to put up barriers to people to keep them out of the building or keep them in at only certain times. So I have felt some support from the higher level. That being said, on a daily basis, I'll have a psychiatrist come into my office and wringing their hands saying, very worried about this person. I think they need to be in hospital. And what sometimes we do is we explore, we try to look more concretely at risk. And sometimes it is in an ethical analysis, there's a perception about risk that may be not borne out empirically. So there's an opportunity to have a robust discussion about history. How is this a change? A good clinical discussion. But at the end of the day, the comfort level of the psychiatrist may be such that the decision is made for a coercive intervention. So, not sure if I answered your question.
Thank you, Simon. I think you provide us a very situated experience in terms of the conundrum sometimes of how to apply these philosophies and ideas in practice. And I think I'm hearing you say that much is added by having a supported and informed team to help work through some of those complexities, and that's probably related in part, in no small part, to the culture of the organization. I do want to go back just to honor what Dr. Rudnick mentioned about leisure, and he notes a paper that Matt then sourced for us, just saying that leisure may be an under focused upon, if that's the real word, area of practice. So thank you very much for adding that. So yeah, addressed enough. Not for resources, but for research and for practice. Looking forward to hearing more about the power, I think, of participation in leisure activities for individuals. So thank you very much. Yeah, and Tracy says thanks to Simon for that helpful conversation. Cinnamon says, thank you, Dr. Davis, Dr. Rudnick and Matthew. This will be a focus I plan on looking forward to study research. Fantastic evidence-informed presentation. So it seems that we may have concluded our session for today. We just want to formally thank our two presenters. Dr. Rudnick, you can't hear me, but thank you very much for presenting. And Dr. Davis here beside me. Thank you very much, both of you, for an informed and I guess a session that really opens the gate to us doing a great deal more thinking, pondering upon, and learning about this topic. So thank you for attending the session. I know that it seems that people stayed for the full session, so it was obviously an engaging presentation. So thank you very much. We really appreciate the opportunity to share the learning this morning. So we will see you the 26th when Matt and I will do a short review of the PSR conference and maybe just look at some highlights of the conference. And in particular, for those of you who can't make it, we hope that that's useful. I do want to bring your attention to something. I'm not sure if you probably can't see it. No, you cannot. But it's the Ride, Don't Hide. It's on June 21st, an opportunity to raise funds for Canadian Mental Health Association, supported by Shoppers Drug Mart. Please register if you Google www.ridedon'thide.com. Don't hide, all one word. We'd love to have you. Love to have you participate. Thank you kindly. And with that, I just say cheerio, as we say in Ireland, and look forward to see you on the 26th. Also, please keep it top of mind that in the fall that we're hoping to do a series on recovery, looking at a model of practice, looking at the recovery-oriented guidelines, and looking at a piece of evaluation. And much conversation occurred, I think, today about evaluation. So we're hoping to do a session on that in the fall. So just to give you a little bit of a heads up. Happy day to you. Wish you well, and look forward to seeing you on the 26th. Bye for now.